should be all right.
Hopefully that's the case. Hello, guys. Hope everybody's having a warmer day. All right. So one thing, your booklet, if the slides once again are really fairly boring, it's more of an outline than anything else. It does refer to different pages and tabs and I'm sorry, I'm blanking on words this afternoon. Charts and graphs and that sort of thing. But the set of slides that I have here are have been modified multiple times, but I guess the last time was a couple of years ago, but have a lot more kind of with the body of the information, a lot more pictures and that in x-rays and that sort of stuff. So hopefully you'll still get what you need. I did review all of your slides, and I didn't have the other pages to go with it, the other charts, that sort of stuff. So hopefully you'll get everything you need. All right, so just kind of starting off, some of these things are some rare things. These are things, some of these things are not even mentioned in your chapter, but one of the things is when we're dealing with some of us who have done some mission work, certainly you can see some of these type of things. This is the difference. We're going to talk about the difference between kwashiorkor and marasmus, and this is insufficient intake of protein and or calories, and so they get this pitting edema all over. If you look at this baby, the feet are just really swollen up on the top of the feet and the legs. And then marasmus, I think of this more as a child, just calorie nutrition that we oftentimes see. I think of more of the Ethiopian child that we always think about, the little tribe of Ethiopian children standing around looking for food. Oftentimes they are hypothermic and have a very low resting heart rate and very low blood pressure. Vegetarian diets or something. I know this talk is going to seem kind of disjointed, but it's because there's just so many different things to talk about. We just want to just kind of get everything to you as the best we can. So basically vegetarian diets are okay. Strict vegetarians do need some vitamin B12. And if they're going to be a strict vegetarian, we also need to make sure that they're going to be on some type of iron, and particularly adolescent females who are starting to menstruate need to make sure that they have some iron in their diet. If they're not going to have it in their diet, that they have a multivitamin with iron. May not be aware, but multivitamins with iron are very difficult to really find over the counter with adequate amount of iron. And sometimes we have to actually write a teenager for a prenatal vitamin, because that will have at least the amount of elemental iron that they need per day. So vomiting is an important sign, of course, of abdominal issues. If it's bilious, we're concerned that there's some type of GI obstruction. Also, if it's bilious, it may just mean that they have vomited so long that they have really emptied their stomach out and there's nothing else to come out. So it just comes out green. It's not you don't ever like to see green vomit, because that usually means they don't feel good at all. They're usually pretty tired of vomiting at that point. If you do see a bloody vomit, of course, we worry about an upper GI bleed. If there's fever associated, of course, we always worry about that they have the classic stomach bug. But they also could have some other systemic infection if there is fever associated. If they are just vomiting and they have no nausea, and after they vomit, they sometimes actually feel better, then that's, classic GERD behavior. If undigested food comes up, that's achalasia, which is actually a topic that I have a slide about a little bit later, but was not even mentioned, I didn't find in your slides at all. Projectile emesis, I think we all have heard about pyloric stenosis being projectile. I will tell you that 2 of my 7 grandchildren, 3 of which are not even related to me physically, biologically, I should say, could hit the wall with their projectile emesis, and none of them had pyloric stenosis. They all just had bad reflux. It was really funny, but all 7 of my grandchildren, 4 of them biologic and 3 of them non-biologic, all of them had reflux to a point that you could sit on 6 feet from them and they could hit the wall with it without any problem. An antral web is an unusual situation, but basically a web around the stomach, which just kind of encircles it and will cause it to really enclose it and make them vomit. Similar type thing with an annular pancreas, because basically the esophagus kind of gets clogged up in there with the pancreas. So it will cause projectile emesis also. Tense fontanelle, of course, you always worry about increased intracranial pressure. But once again, a tense fontanelle is not something, as a general rule, you're going to miss. And of course, we're also talking about smaller babies that, their fontanelle hasn't closed off. So that's just a very short period of time that you can really tell that. In the older adolescent, we do worry about certain, of course, about them possibly being pregnant. We ask that question a whole lot more than most mothers want to hear us ask that question, or fathers, or friends that are with them on the visit sometimes. Drugs can cause vomiting, and also, adolescents who have migraines or sometimes have vomiting associated with it. And then we also worry about bulimia. We have, well, I shouldn't say an unusual, but I think that the mental health aspects of vomiting are a larger percentage of of adolescents that we see. And I would just mention, when you're dealing with anorexia, I think typically a lot of people think of the girls, but I would say that in my practice, at least 15 to 20% have been boys. Persistent emesis that we have an unclear etiology, sometimes we just end up with chronic vomiting. And we have to do some evaluation of that. And I will tell you that even with doing all the testing that's listed, which we try to do non-invasive things first, abdominal ultrasound, and many times that's going to be normal. We probably here in this community would do an upper GI next, just because that's something that they don't have to go anywhere else for. When you're dealing with adolescents and children younger than adolescents, in our community, our GI people will normally not do anybody less than 15 or 16. So we can't get endoscopy in a larger city. The after an abdominal ultrasound, if it's normal, the next step would normally be to send them to Peds GI and get endoscopy. There's cyclic vomiting is kind of interesting, because they may have several days that they even vomit, and then they have just totally normal, good health for weeks and weeks, even months and months at a time. More common in girls ages 6 to 7. Sometimes there's several weeks between the episodes, as I said, and it is sometimes associated in families that have migraines also. But you have to make sure there's not some organic disease. And I have had one patient who had this, who was successfully treated with beta blockers for about 1.5 years, and it just went away after that. So acute abdominal pain is one of the most common things. I just noticed where that little red thing is up on the wall. It looks like something red's growing out of the top of my head. I promise I don't have anything red out of the top of my head. Okay, so acute abdominal pain is one of the most common reasons that people present to the emergency room. We get a copy of every emergency room visit for our patients. So I will guarantee that when I pull up my computer today, I will have had 1, 2, or 3 people there for abdominal pain yesterday at one of the hospitals for sure. But only less than 5% end up being admitted for this diagnosis. So obviously, if there's trauma associated, in children, one of the most common things we see are seatbelt injuries causing abdominal pain. But, you know, if it's some other type of trauma, you worry about, you know, an intestinal perforation associated. Obviously, if they unfortunately have been shot, stabbed, whatever, you know, hemorrhage related, musculoskeletal injury of some type, and then acute pancreatitis. We've got a slide about that in a little bit, but those kids do present really feeling poorly. Bilious vomiting, of course, as we talked about, we always worry about obstruction. Peritonitis, we worry about appendicitis, obviously. But a bad case of cholecystitis, most likely in, you know, statistically more common in a slightly obese female, adolescent females, most commonly. But, you know, when you have the 6 or 7 year old boy, which I had 4 or 5 years ago, skinny, who had gallbladder disease and gallstones, it can happen to anybody. You just have to think about it. And then pelvic inflammatory disease. I will tell you that gynecology is kind of put into a totally separate category. It's just,
hold on.
Okay, hang on.
Okay, you should be all right.
All right, so that the pelvic inflammatory diseases and all the gynecologic things are going to be handled more in your gynecology section if you haven't done that already. So obviously with our adolescent females, we have to involve the, you know, pelvic inflammatory disease, pregnancy, something to do with like Mitchell-Schwartz, which, you know, is that halfway in between ovulation time period between in your period cycle and stuff. And it can be very symptomatic, and sometimes also the other thing they didn't really mention, but, you know, torsion of the ovary. I actually had a 3.5-year-old who whose mother worked at the clinic, whose 3.5-year-old presented with this, you know, one-sided pain, of course, right-sided at the time. And she actually went to surgery at that time. This was back before we were doing a lot of CT scans and all that for abdominal pain, and actually before we were doing a lot of ultrasounds. And the concern was that just in her age group and her size, and she had an elevated white count and a little bit of fever with it. And so, but when we got inside, it was a torsion of her ovary. Current jelly stools. Somebody always asks about what does current jelly look like. Well, it looks like kind of strawberry jelly, but kind of a thin strawberry jelly, so to speak. And but causing intussusception, I have a slide about that in a few minutes too. Melena is an upper GI bleed. You know, that just means it's gone all the way through, and it's more of a dark, more of a brick color at that point. And then, you know, there's just a lot of non-specific causes of acute abdominal pain. Toxins, you wouldn't think would be a really high number there, but particularly during tobacco season, we have, you know, people present with green tobacco syndrome, which is common around these parts, and they do present with abdominal pain with that sometimes. Severe UTIs are usually the classic, usually one-sided, and, you know, blood in the urine and pain with urination, and sometimes bladder spasms associated, but not always, particularly in younger children. Pneumonia, particularly a lower lobe pneumonia, elevated white count, not necessarily much cough yet, but because that lower lobe pneumonia, there's just that thin diaphragm between the lower lobe and the upper area of the abdomen that oftentimes leads to abdominal pain, usually an upper quadrant pain, and then functional abdominal pain, which we'll talk more about. So functional abdominal pain usually lasts for longer than 3 months. It's usually a school-age child. It's rarely children less than school age. You know, there's certain stressors that seem to bring it out worse. Normal exam, there's usually rarely significant weight loss, even though family will sometimes come in and say, oh, they're not able to eat because every time they eat, it makes it worse. Stool is, you know, if you're looking for occult blood, it's always negative, and they have a normal laboratory screen. The pain sometimes awake, if you're concerned, and you start looking, you know, is there an organic cause we need to go for? Well, these are the things we're concerned about. Does the child get awoken at night with their pain? That's highly unusual. Is the pain not at their belly button. Most kids with functional abdominal pain, when they come in, they point straight to their belly button, and they may sometimes make a little circle around their belly button, but it's always right in their belly button. Certainly, we're always going to be concerned if there has been weight loss, or if we have a smaller child, and particularly a baby who is failure to thrive, they're not seeming to gain weight the way they should. Obviously, if they have fever, rash, joint pain, mucous membrane changes, ulcers, if it burns when they pee, if they seem sleepy after their attacks, we have a slide about this in a little bit, but there are such things as abdominal quote unquote seizures, things that after a seizure, some type of period after that period of time when they seem very sleepy. Guaiac positive stools, obviously, we're always going to be concerned about, but we have to look and see where that blood is coming from. We have a slide a little bit later to talk about that. We worry about anemia. We obviously worry about elevated sed rate. Are we dealing with a Crohn's? Are we dealing with some type of other inflammation somewhere? And then, is there a family history of ulcer disease or inflammatory bowel disease? If there is, you can bet the child is going to need some further workup to make sure they don't have it also. Certainly increased risk of that. Diarrhea lasting less than 14 days is considered an acute episode. In children, it's almost always from infection, but toddlers can sometimes get into what we call a toddler's diarrhea, and it's controversial how long that has to last before you call it acute or chronic or call it toddler's diarrhea. I have some kids that I would say that it's less than 14 days, but I would still go on and put it in a toddler's diarrhea category, because it's almost in toddlers, so to speak, and in 3-year-olds and 4-year-olds, it's almost always related to juice intake. And it's also then related to, after they've gotten the diarrhea, then the family insists on, well, let's give them some milk if we're not going to give them juice. And they've lost the lining cells along their GI tract, and they cannot break down that milk. And so if they don't have the milk broken down, then it's like they slough off their GI tract, and that's not a good thing. And so they have some very, very loose stools at that point. So we do worry about if the child is less than 2 months old, and this does happen sometimes, because you can sometimes have, particularly if they have a school-age sibling, they may have picked up just what in the school-age sibling was a stomach bug, but bring it home to a small baby, and it can be very bad. Obviously, if there's blood in the stool, then we really worry about Salmonella and Shigella in particular. If there's leukocytes in the stool, and the only way to know that is for you to get a stool specimen and have them look at that for leukocytes for you in the lab. If you've got a toxic appearing child, okay, no matter what's going on, whether you're evaluating diarrhea or whatever, obviously that's something that needs further evaluation. And then if they have diarrhea, which they have developed while they're in the hospital, is it because they are possibly on some antibiotics that have caused it? And in particular, of course, we're going to worry about Clostridium difficile. So generally with diarrhea, we treat with oral rehydration therapy. Now, the problem I find is that people think, oh, we can just do that for several days. But remember that our products like Pedialyte and Rehydrolyte, those type products, have only 6 calories of, 6 calories, period, per ounce. Normal formula, for example, is 20 calories per ounce, and most breast milk is somewhere between 18 and 22 calories per ounce. So if we give somebody 6 calories per ounce of Pedialyte, for one thing, that baby isn't going to be real happy, because they're going to think they're starving to death. It's quote unquote thin. They're not going to feel like they're getting much. But the second thing is going to happen if you do that for any prolonged period of time, that they can get into what are called starvation stools, because they're just not getting any calories in there. So I think that it really depends on the age of the child, but there are times that I never actually go to Pedialyte in a really small baby. But instead, I might, if they're breastfed, I might have them mix Pedialyte and breast milk in a bottle, just a small amount sort of thing for a couple of feedings, and just to try to kind of let their stomach rest a little bit. And then we want to avoid something like Gatorade or, you know, high calorie fruit juices and soft drinks. Now, the minute I tell you that, you know, we always talk about Gatorade being great to rehydrate with electrolytes for our athletes and stuff. But what we have to do is we have to put that Gatorade, you know, we have to dilute it. If you're gonna use Gatorade, remember, number one, it has a very high carbohydrate load too. So it's kind of like drinking straight Kool-Aid with some electrolytes thrown in there and stuff, but like a concentrated Kool-Aid, so to speak. So if you're going to use Gatorade, I dilute it half and half with water, or it certainly doesn't need any extra electrolytes and stuff, so you don't have to use it with Pedialyte. I put on their soft drinks, you know, to avoid that completely, but you know, I have some kids that are just, you know, they won't take anything. And so if Sprite is, or ginger ale is the only thing you can get in them, I'd rather get that in them than water. You know, people have this concept, oh, I got him, you know, he's had, you know, 2 quarts of water today. Well, water is a wonderful thing and it will keep you from dehydrating, but it doesn't have any calories in it. And that makes you even weaker, you know? And so, you know, there are those times that I, you know, kind of beg off and end up saying, no, well, you can do that if you have to, but I would much rather, you know, use one of the solutions that are made for that. But remember, short period of time, and then back up to regular, whatever their normal substance is as soon as possible. So obviously, if they're shocky, the last thing you want to do is use oral rehydration therapy. And if they are putting out just like pure water, which, being honest, we used to see a lot more of before we had the rotavirus vaccines, then, you know, those kids just had to go straight on the IV. It just didn't help. And then also, if you did an x-ray for any reason and you saw an x-ray that they had an ileus, or in particular, you actually even used your clinical skills and found out that there were no bowel sounds, that would not be a good time to, you know, try oral rehydration therapy, because it's not going to work. And then for whatever reason, if they're having some monosaccharide intolerance, which doesn't happen that often, but if the family knows of that, they will tell you that anyway. But resume the regular diet just as quickly as you can. Constipation. The majority of constipation is a functional issue. And the number one issue that I see is related to there are two main things. Number one, with potty training, and that is the child that wants to be have control over their bowels. Okay, so you know, pee-pee is one thing. You start to pee, and then you could kind of start, stop. You know, they kind of get control over it. But one of the things that happens with poo-poo is once it starts to come, as a general rule, it comes. So you will see occasionally toddlers like run through the house with their poo-poo coming out of their bottom because they're scared of their poo-poo. And that's because they can't start and stop it as well as they can with their pee-pee. So that's one period of time that almost all kids will have some issues with it. Interesting enough, those kids that have sort of loose stools most of the time in that age group usually don't have a problem with it, but it's kids that have a tendency to be a little bit more hard, and that's because they've held it in, you know, have more problems with that. It is a vicious cycle because they don't go, it sits in there longer, that makes it harder and bigger, and then the next time they go, it hurts when it comes out because it's harder and bigger. And then we get into that vicious cycle. The next time we need to go, it's like, oh no, I'm not going to push it out because it hurts. This is the things that are going on in their mind. So it's just, that's a vicious cycle. Then the second issue, that's a behavioral issue that comes up, is that the school age child who one of two things happens with them. They all go and have their snack at 9 o'clock, and then they have lunch when they're in kindergarten. They have snack at 9 and they have lunch at 10:30, and then at like 10:50 they all go to the bathroom and they're all supposed to poop at that time. Well, pooping on command is not something most of them can do. And they get into a habit of, I will never poop at school. Now, this carries through to high school, at which point they actually sign a form when they go in the high school front door that says, I will never poop at school. And so some kids will actually have to call their parents from high school and say, come pick me up because I have to go to the bathroom. Okay. You think I am lying about that, but it is not. It is really true. So this is particularly a problem in elementary school when kids can't really call their parents to say, I need to go to the bathroom and you've got to come pick me up. But they will hold it and they will hold it. And you'll sometimes even see them running around on the playground, and just all of a sudden they'll stop, kind of put their legs together, kind of hold, and you can see them kind of holding their breath a little bit and stuff. And you think, oh, they're just holding, they're maybe trying to not pee on themselves. No, that's not what they're doing. They're trying to hold their poo-poo in. And it'll sometimes work. If they can hold it there for just a minute or so, then, or sometimes 30 seconds or so, they can do that. So that's the issue with that. But a very small percentage of children actually have an organic cause. I will tell you with newborns, some breastfed babies will only stool like initially they all poop a lot, no matter whether they're breast or formula. But then in that first, somewhere between 2 and 4 weeks, they get to be what's quote unquote normal for them. And some breastfed babies, it's only every 5 days, sometimes every 10, 12 days. And what they do at breastfed babies is that they utilize what they take in, and then they have a massive blowout when they do go to the bathroom. So functional fecal retention is the most common non-organic cause of constipation. So constipation depends on the age of the patient, the cause, and the degree of the functional problem in the patient. We oftentimes have babies that come in and the baby's not uncomfortable, and if there's not poop down there ready to come out, if mama has done some rectal stimulation, I don't care. As a general, if it's been 3 days, 4 days, 5 days, as long as the baby is not uncomfortable, and they just haven't gone to the bathroom. I hate to say it this way, but I don't really care as long as they're not uncomfortable and stuff. But we monitor it, and we try to give the family a few little things to do and make them happier and stuff. And so in an older child, we decrease the milk and milk products, and somehow or another families will do that for like 2 or 3 days and things are better, and then they'll just start giving them back to them. So we try to increase the amount of water they have. They have to have, I shouldn't say that. Most of the time at school, they have to drink milk. We can send a note so that they can have water or juice instead, but some of the juice products that they offer them, I think sometimes water is best, but we want to increase their water, their fiber of any type, and then their veggies and fruits. And then we consider Miralax. Miralax back in the 90s was a experimental drug that when we sent people to Vanderbilt for their chronic constipation issues, because we had used everything we had, which was mainly like Colace and Dulcolax at the time. They were on this thing that had these numbers, experimental drug sort of thing, and they were all great. And we found out later it was Miralax. And now Miralax, after being used for almost 30 years, came out, and now it's supposed to cause all kinds of chronic issues. It's, and I don't know what any of them are true or not. I have a couple of family members that have been on it. Let's see, for one of them 18 years, on one of them 6 years, and they've done okay with it. And it's amazing, when they quit taking it, they have problems, and when they take it, they have no problems. So it seems to work. So in young infants, we used to use the dark Karo syrup for years and years and years. Why this is true, the dark works better than the light. I can't give you a scientific reason for that, but it's actually true. Now, Vanderbilt, even in the newborn period, is using prune juice with babies. I've had a couple of babies that have had GI issues and had problems with poop kind of working its way through for various reasons. Some of them had had some abdominal surgeries for different reasons and stuff. But babies are being sent home from the nursery in the first 2 weeks of life, sometimes on prune juice. It's wild to me, but it's happening. They use a 1 ounce bottle of half water and half full strength prune juice. And just for information, the people that they've started on that, I continue. I would, as a general rule, in a 1 month old, we would not ever be treating constipation. But anyway, just for information, you may see some stuff about that. So tracheoesophageal fistula and esophageal atresia itself, just a nice little diagram on here, which I think, by the way, was better than what I could see on your little stuff. So anyway, very unusual thing, the way these kids present in the nursery usually is that they develop some respiratory distress. They'll be drooling. They can't swallow their secretions. And it's sort of like one of those things you're really not going to miss it. It's oftentimes associated with what's called bacterial syndrome, which used to be called Vater syndrome, but they keep adding more and more things into that. But it's an association associated with vertebral anomalies, anal atresia, cardiac, the TE fistula, renal abnormalities, and limb abnormalities. The one child that I've had with it, who's now 6 here, he had a club foot with it. He also had anal atresia and had lots and lots of issues with that, and had to be had a new anus made, and then he had to be dilated off and on a lot with that. So esophageal atresia with a distal TE fistula, you can just diagnose that with an OG down the down, and it'll wrap around and stuff. And then, as we were talking about, some of them will have excessive secretions if they have the esophageal atresia and not the TE with it. And then some of them will just choke during feeding. The H type is supposed to be the most rare type, but the 3 ones that I've had in my experience of 35 years, or now almost 36 years, 2 of the 3 were actually H types. And then those ones, like with a web diaphragm, like we talked about, that's similar to that antral web and stuff, and they just do very poorly when you get to a bigger consistency coming through, like with solids. So this is an example of the OG going down, and it just stops, and that's associated with esophageal atresia. So it shows just the coil tube and no air in the stomach. We notice normally there's going to be an air bubble in the stomach, and there is no air getting through. By the way, that big thing on the baby's right side, that's the umbilical cord clamp. It looks like an extra bone coming out of its body, but it's their cord clamp. Achalasia is, which is not listed in your stuff, by the way, is just an abnormal relaxation of the lower sphincter, and you don't get the normal peristalsis that goes along with the esophagus. GE reflux is probably one of the most common things that we see as a cause of reasons that we have people come to the office. It's felt that 50% of all babies 0 to 3 months have some degree of reflux. I will say that many times this is related to overfeeding, and it's not so much that the caregiver is actually trying to overfeed, but the baby is overfeeding themselves. And that's the reason sometimes, we have to physically take the bottle out of the mouth or the breast out of the mouth and like burp in between every ounce or so, or what period of time that you're doing if you're breastfeeding, and then go back at it just to physically slow them down. And then it says 2/3 of 4 to 6 month olds. And that's just because, once again, when you get up to a certain volume, you have an increased risk of reflux, because particularly if they're taking their bottle or if they're breastfeeding and then they're gulping at it, they're going to swallow more air. And so if they have a tendency to reflux, it's going to come back out because there's only so much air, so much volume in the stomach, and you add the liquid and you add the gas to it, and that's what happens. Usually it resolves by 2 years of age and no treatment is necessary. We call it GERD, though, when the clinical symptoms start to appear. That's failure to thrive, pain. And how do we know when a baby's in pain? Usually they'll do some arching. They also will act like they have a lot of pain after, if they do vomit. Those are the ones we worry about, that, they really are having some esophagitis type burn after they vomit. So, we would love to be able to have a pH probe that was really available here. And, or, obviously endoscopy, but what we're left with doing many times is an upper GI if we need to. And another reason we sometimes do that is if we are having projectile vomiting with it, as I said, sow babies can do that projectile vomiting thing. The nice thing about doing an upper GI sometimes is you can also make sure that they don't have pyloric stenosis, although with pyloric stenosis, we usually diagnose that another way if we're really concerned about it being pyloric stenosis. And we'll talk about a little bit of difference in the way they usually present. But it just, in communities this size, we're just not going to have pediatric GI people here on a day-to-day basis to either do a pH probe or endoscopy. GE reflux treatment is usually with reassurance. And I will say that, the PGI people always say that, you shouldn't treat them with medicines. And so the ones we send to them that, we're not treating with medicines and they're not doing very well, they treat with medicines. And then surgery is very, 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 very rarely done with kids. You may have heard of the term Nissen fundoplication, which basically involves kind of wrapping around the esophagus and kind of making the lower esophagus work by wrapping around it and making it smaller. And it's just not it's a big, ugly surgery. And it is really only used for the worst cases these days. And it would not be anything as a general rule that would not be done in a tertiary care center at this point. So infections of the esophagus are rare. Kids that have HIV, diabetes, cancer, long-term steroid use are more common. The most common organisms are any type of esophagitis. Always think of fungal candida. It can be CMV, and there have been associated cases with herpes. Ingestions, the good news is, well, good or bad, I guess we just don't seem to see as many toxic ingestions as we used to. I guess most people have figured that out, that, you don't leave a lot of stuff around in your garage. And and also, they've learned about safety caps and putting things in, brightly colored things that make it look more like Kool-Aid or something. They try to avoid that. But basically, if they're drooling, if it acts like it hurts when they swallow, abdominal pain, all those things you have to worry about. And, once again, a lot of these things, the most important thing is you don't want to induce emesis, because you can actually make it come back up and it can actually cause more pain. But many of them have to be shipped away at this point from our place to a pediatric GI person so that they can be scoped. Pill-induced esophagitis can happen when a pill just basically adheres to the back of the esophageal wall. There are certain pills that are more likely to do this. The tetracyclines, which are usually not, well, they shouldn't be used in children less than 7. NSAIDs and aspirin. So, your ibuprofen and that sort of stuff can happen with that. And potassium. We don't have too many kids on potassium, but some of our cardiac kids who have to be on potassium products because of their diuretics that they're on are sometimes on it. So it can happen. Foreign body, usually you're going to hopefully be able to see these on chest x-ray. It says 90% are radio opaque. I'm not sure that 90% is really true anymore, because it seems like we're getting more and more of these ultra hard plastic things that people are doing. So remember, if a coin is in the coronal plane, that means it's in the esophagus. If it's in the sagittal plane, that means it's in the trachea. And I will tell you, half the time you can't tell whether it's coronal or sagittal. So many times they are, endoscopy is actually required to get those out. Pyloric stenosis is 1 to out of 200 to 1 to 750 live births. It's 6 times more common in males. It presents between 3 weeks of age and 2 months of age. It's usually non-bilious unless they've emptied their stomach out completely. Projectile vomiting. Remember the classic thing that is on every board's exam for us docs, and I think every nursing test that you guys take either, is that you get a hypochloremic alkalosis. But that doesn't happen automatically, but if it's been going on for 10 12 hours, it's going to show up. Abdominal ultrasound, you will see what's called a railroad track sign or track sign. And so basically the pylorus, the last part of the stomach, will just stop in with the there's just basically the outline of like a railroad track, and then there's just very little that's going through there. The great news is with a pyloromyotomy, usually the babies go home in 36 hours or so and on a full diet. We have it's pretty classic, but there's orders right now that as soon as they get out of surgery, they are just built back up on their volume. Now, I will tell you that unfortunately, some of these babies are lucky enough, because we said, remember, 1/3 of the babies in that age group have reflux also. So some of them will have reflux at the same time. And so you don't have complete smooth sailing, because some of them will still spit up a little bit, but they usually do really, really well. When John Y. Brown was governor, his wife, Phyllis George Brown, who was Miss America and all that sort of stuff, their first child, Lincoln Tyler Brown, decided he had been a premature baby. And so he decided at 2.5 months of age. And when I was on call for the University of Kentucky, and his neonatologist that took care of him decided that I should see him in the ER, when in the middle of the night, he was been having problems for a couple of days. And sure enough, he came in. We were not doing abdominal ultrasounds at that time to diagnose this. He had an upper GI, and he did have pyloric stenosis and went to surgery during the middle of the night. He was probably my most most famous patient, other than one of the thoroughbreds that cost like a colt that cost $2.5 million that was born prematurely, that we treated on the ventilator. Yes, it's true. I went to a horse farm and treated a horse on a ventilator. Crazy, but true. Pyloric peptic ulcer disease, very rare in children, but can happen. It's almost always related to H. pylori, which of course we can do a blood test for nowadays. But it's also diagnosed by endoscopy and biopsy. Antibody testing are not completely accurate and acceptable diagnosis, but once again, if you have a child that seems to have symptoms, but they're not acutely ill, you can treat, you can get the H. pylori, you can start to treat them. And then if they're not getting better, then you can send them to Pete's GI, and then endoscopy and biopsy only if needed. I mean, we treat a lot of things by, we treat them, and if they don't get better, then we send them on. Zollinger-Ellison syndrome, I have had one of these. This is, unfortunately, it's caused by a gastrin-secreting tumor of the pancreas most of the time. And it's associated with that cluster of what's called MEN1s, and there's also an MEN2, and it's multiple endocrine neoplasia type 1s. So anyway, just something to be aware of. And malnutrition is kind of interesting because it can present at any time in childhood. And if it's in infants, they get a bilious emesis due to due to it wrapping around, and then it'll kind of stop. And if you notice on my little picture here, you can see that little beak coming out. That's called a bird's beak. And then if you also see down below that, right below the tip of that red arrow, you can see that little corkscrew look to it and stuff. And that's just really very, very common with it. One of my cousin's children was, we were at Christmas talking about the fact that she'd been admitted like 3 times in a 5-month period, and she was about 4 or 5 years old at the time. And as you went back and looked at things, I mean, this had been going on really since she was a baby. And I said, you know, have they checked her for either a malrotation of some type or midgut volvulus? And she goes, no, but you know, next time we'll see if there's anything I'll have them check for that. And next time, sure enough, that's what she had, and it got fixed. They went in and tacked down the momentum there, and she didn't have any more problems. So once again, a slide that I really like my view of this than your slide, the intussusception. So most commonly occurs between 2 months and 5 years of life, but most of the time, most between 4 and 10 months. And the oldest one that I've actually ever had was an 8-month-old. And that 8-month-old, his was, it was the second time that he had actually had it. They're almost all 4 to 6 months they have been in my practice. Almost all of them are idiopathic. They present with abdominal pain, vomiting, and bloody stools. Now, how does a 4-month-old tell you they have abdominal pain? They lay completely still. They do not want to be touched. They do not want to be held. They do not want to be cuddled in particular. They will have just a very stoic look on their face, and they will whimper if you try to touch them. Usually after they've been laying there in pain, they will sometimes have that, we talked about that current jelly stool. Sometimes they'll have a mass that you can feel, and what you're feeling with the mass is you're feeling this intussusception. And I think the easiest way to explain it is just the bowel telescoping upon itself. An air contrast enema is diagnostic and therapeutic if you can get one of the radiologists. Particularly, these seem to always happen in the middle of the night. But if you can get one of the radiologists to come in and do it, it's not something that a tech can do and then, you know, have them read it later or whatever. Sometimes they have to go to laparotomy. Not that they end up with a colostomy or anything, but they have to physically, if it's been in for a while, if it's telescoped in itself and it's been in for a while, they, you know, you have to physically pull it apart sometimes. Duodenal atresia, whichever way you want to pronounce it, is about half of all intestinal atresias. It's associated with a lot of different things. They usually have all these other things going on. 40% have trisomy 21. In my case, I've had 3, and all 3 of mine happen to have Down syndrome. But this classic double bubble, you will not ever see anything else that looks like that. And it's just very, very specific on X-ray. Obviously, they present with not being able to handle any secretions, not being able to handle any food whatsoever. If you notice, there's no gas beyond the duodenum, so you know nothing is getting through. Obviously, they're not going to have any poop come out. Meckles, you know, I've been going 36 years at this, and I've yet to see a Meckles, although they always talk about looking for it. I checked with a couple of my other partners, one who'd been here 33 years and one who's been here 22, and none of us have ever had a Meckles. But basically, if you saw bright red blood coming from the lower part of the GI tract, then we worry about a Meckles. There's something called a Meckles scan. I have ordered a couple of those, but have not. It's just very, very unusual. That rule of 2s is something that's always talked about, though. It's supposed to be 2% of the population has one to begin with. It's usually 2 feet from the ileocecal junction. It's usually 2 inches in length, 2 centimeters in diameter. Males are 2 to 1 over females. And usually it's never a problem before 2 years of age. But like I said, we're still looking for it. Lactase deficiency, very common. A breath hydrogen test is the best for diagnosis, but guess what? That's another thing we can't do really here. That's something that's done at a tertiary care center. But once again, even they're oftentimes going to do an endoscopic biopsy if there's concern over it. Short gut syndrome, malabsorption disorder from shortened intestinal length. Basically, if you have a child that has had, you know, and nowadays when we have babies in the NICU that have had necrotizing enterocolitis, and let's say they've had part of their gut removed from that, then if they have greater than 38 centimeters of small intestine, they're going to survive. That's the bare minimum. That's the amount they need. And if they have less than 15, they're definitely going to die. Those less than 15, there have been some of those that have gone on and been transplanted later. And if the rest of all their organs were stable enough and stuff, there have been now a few that have done okay with that, but it's just short gut syndrome is one of the worst things that can happen as a complication of the NICU. Celiac disease, this is, you know, the disease of the month club. Everybody thinks they have gluten sensitivity these days, but it is associated with, if we're more concerned, I should say, obviously, if there's a family history, and then also if you're less than 2 years of age, they've had some degree of failure to thrive, they have like a distended belly and some muscle wasting and stuff. They oftentimes have this dermatitis associated with it, and, you know, sort of this history of kind of this, you know, atopic disease in general and stuff. It's an autoimmune disorder. Children with type 1 diabetes and any type of IgA deficiency are more common. It's also much more common in Down syndrome. Just like Down syndrome's in the last 30 years, this has come about that we started looking for thyroid disease in Down syndrome, which is really high. Well, celiac disease appears to be going to be the next thing there. The screening is a panel of antibodies testing. There's like 4 or 5 of them. You don't have to have all of them, but, you know, you got to, not just one of them being abnormal is enough to cause it. And then it's confirmed with a small bowel biopsy. And you can make it go away with just a gluten-free diet, which is easier said than done. 25% of siblings will end up getting it. Ulcerative colitis, just the colon, endoscopy again, continuous lesions, involves the mucosal surface only. Usually some weight loss. If you look at their x-rays, along the colon, there's no ulcerations. And so it looks just like smooth colon. And that means that it's denervated. And so there's not any movement along through there. So there's a lot of different things that can happen with that, but gross rectal bleeding and the mucosal surface of what's coming out there at the anal opening oftentimes is really nasty looking stuff. Crohn's is not necessarily just restricted to the colon. They will have some skip lesions. It's what's called transmural disease, so it goes all the way through the thickness of the GI tract, of the GI, I should say. Granulomas can happen. Severe weight loss is very common. X-ray, you can pick up those skip areas, and then that thumbprinting that can sometimes happen. There's a lot of different meds have been used. Surgery is non-curative, but I will just say that in my practice, these are most of the time are adolescents who present with a history of very non-specific abdominal pain, sometimes diarrhea, almost always weight loss. And I've been concerned sometimes that they were being anorexic on me. Remember that they're going to be anemic usually, and their SED rate's going to be elevated. On a plain x-ray, most of the time you're not going to pick up anything. But if you've got an elevated SED rate and they're anemic, then they go straight to PCI. There's a couple of questions on here because this was initially done for a grand rounds, and so you're supposed to do something that would you have to have a couple of questions on there for people to answer. So this one, 10-year-old boy, abdominal pain, periumbilical. There's no history of trauma. He's had no fever, sore throat, headache, dysuria. His mother describes his emesis as green. Physical exam, the child is in obvious distress other than mild tachycardia. His vital signs are within normal limits. His abdomen is diffusely tender with localization to the periumbilical area. He's also complains of increased abdominal pain when his heel is struck by the examiner's hand. Rectal examination reveals no evidence of occult blood. So this question isn't really to trick you, but it also is to make you think a little bit, because yes, when we talk about periumbilical, it's usually functional, but he has some other things that are not functional there. He's got green emesis, he's got mild tachycardia, His abdomen is diffusely tender, and his localization is to the periumbilical area, but he's already diffusely tender all over. So this young man actually has appendicitis. Juvenile polyps are common. Usually you'll have painless rectal bleeding, and polyposis is usually they'll have 5 to 10 rectal polyps. Peutz-Jeghers is an unusual syndrome, but you'll see these unusual macules on the lips. I have one family here that has this syndrome. Phallus cells are interesting to me. I guess I've had 3 or 4 since I've been here. I can't remember exactly, but it's a defect in the abdominal wall, right, of course, right through the umbilicus. You can have, all the organs through there or part of the organs. It's really yucky, but most of the time, if we know it's going to happen, they are going to deliver at a tertiary care center so that they can pretty much go almost automatically back into surgery and get that taken care of. Now, if they're born here, or even then, if they're born there and they, born at one of the tertiary centers, we cover this with a protective coating of like a silastic material and stuff, and kind of keep it moist and stuff until that they can go in and push everything back in. A certain percentage have an associated congenital abnormality. Interesting enough, my kids have had Phallus have not, none of them have had any other association with it. And like it says, it's obviously, if they have other anomalies, they're more likely not to do well. Gastroschisis, it's usually to the right of the umbilicus, and it just happens to be, right there at the umbilicus also, but it's actually through the wall. Now, according to when this occurred in utero, if it's been out, so to speak, for a while, then those loops of bowel can be hard as a brick, and those are much more difficult to repair. So those are put into also a silastic band. And what you do with that is it's kept moist, and also that keeps it from getting infected, as you can imagine. And so then it looks like a mound, so to speak. And then every day they kind of turn it down a little bit and a little bit and a little bit. And to a point, it takes a long time for that to kind of be able to be close to going back in that small little hole. And so, but what they do is just with time, it does go down some. And then when they get it down as much as they think they can, then they'll go in, open that slit just a little bit more, and then put everything back in there. As quickly, these are the ones that you don't want it to be missed a long time in utero, because as I said, it will turn into almost like a brick wall sort of thing. Hirschsprung's, 1 out of 5,000 births. Remember that also the ganglionic neurons aren't there. And so once again, it's not pushing things through the colon. Very common with Down syndrome. And this is why we always ask that question in the newborn, if they poop in the first 48 hours. But the last one that I had pooped 3 times within the first 48 hours. So you can't really use that as a rule of thumb. And so the rectal biopsy is the best way to diagnose that, and it has to be treated with surgical resection. Schwachman-Diamond syndrome is autosomal recessive. I have not personally had one, but one of the ice skaters, I can't remember which one it is, but he was with the national U.S. team, had that, and they're usually short stature and have some other abnormalities. Acute pancreatitis, I just really put that on there for you to see the colon sign on that picture, that bluish purple sign. They are really usually sick. They usually have fever associated, and you're not going to miss it. But basically, obviously, on the diagnosis, you're usually going to see an elevated white count and amylase and lipase, and can usually be detected on ultrasound also. Chronic pancreatitis is usually associated in families. It's autosomal dominant, and they 80% present prior to 20 years of age. Choledochal cyst, 1 to 13,000 or to 1 to 2 million live births. abdominal pain, jaundice, and palpable right upper quadrant mass. Ultrasound shows the intrahepatic and extrahepatic biliary tree dilatation. I had a 2-year-old present with this, and she basically looked like a gastroenteritis until she started getting some jaundice and stuff with it. And really wasn't that sick with it at all, but jaundice was not a normal thing in her for sure. This Alagille syndrome, if I've ever seen it, I don't know anything about it, but mutation on chromosome 20, and I didn't see it in your book, so I don't think you need to know anything about it. So 15-year-old, 3-week history of fatigue, 2-week history of temperature, a 1-week history of jaundice. She admits to both unprotected intercourse and intravenous drug use, my kind of patient. On PE, she has an enlarged liver with a span of 9 centimeters. Laboratory reveals a elevated AST and an ALT. They're both really elevated. In the patient of this age, the viral infection associated with the highest risk for the development of chronic hepatitis and cirrhosis is. So if, you have to be kind of careful when you're reading these kinds of questions, because statistically, the most common cause of her infection is, fatigue and low-grade fever, and even the 1 week of jaundice would be Epstein-Barr. But the question actually says that the highest risk for the development of chronic hepatitis and cirrhosis. So the answer for this particular person is hepatitis C. Okay, and they threw in those things about the drug use and the unprotected intercourse also. So, all right, Hep A, usually, acute infection. This is one thing that Kentucky has been proactive about with immunizations. It's really nice that we're able to, we vaccinate kids for this now, and we have been for many years before a lot of other states have been. And I did have a mother of one of my children that she did not want him to have it when he was a child. And then she was unfortunately, she had cancer, and honestly, I don't remember what kind of cancer she had, but when he did get hepatitis A, and he wasn't particularly sick with it, she unfortunately got hepatitis A and died in a fulminant hepatitis. So just a little schematic there showing how all the different antibodies and how they usually go. Usually all the same things that you would expect that you with hepatitis B is 1% case of developing fulminant hepatitis, 5 to 7% that develop that chronic carrier state. Of course, hepatitis B has been vaccinated against for a long time, but one of our issues locally is that we have a lot of immigrants, and so we at least it seems like once a month we'll have somebody born who's a hepatitis B positive mom, and then in those babies we have to give what's called HBIG, which is hepatitis B immunoglobulin to the baby, and also their first hepatitis B vaccine while they're in the nursery, which we do anyway, but we also have to give that immune globulin, and then obviously make sure that they get their next vaccine when they're supposed to. And then we do antibody studies on those babies at 9 months of age, just to make sure that that they got a response to their vaccine. Hepatitis C, IV drug users, those sex behavior, tattoo parlors, bad problem, body piercing also. A lot more written about this recently. Now, so there are some more effective treatment plans for Hep C, but still out there. Hepatitis D is one of those things that's interesting out there. One of my attendings in medical school actually ended up dying from hepatitis D in, I always get it confused, Iraq or Iran, when he got called over there for military service, and he got a fulminant case of hepatitis related and died awaiting a liver transplant. And hepatitis E, another one that can also go into fulminant hepatitis, particularly in pregnancy. Autoimmune hepatitis, I'm not going to say anything about that. There wasn't much in your book about that either. Gilbert syndrome is kind of interesting because it's very benign, but the only thing that you're going to really see is that they get some hyperbilirubinemia. If they are stressed, or if they're sick, or for some reason, if they're fasting, the whites of their eyes turn yellow, and that's all you see. They don't get jaundice enough on their body, I don't think, for them to look different. I had a young boy, and the first time I saw him, he was like 3 or 4 years old, and the whites of his eyes were yellow, and did liver functions, and his bilirubin was 2 or 3 or something like that, and all the rest of his liver functions were normal. And I asked the family, anybody else in the family have this? Blah, blah, blah. No. Well, then the next time they came back, and he actually wasn't his eyes were not icteric at that point, and they said, oh no, well, we found out, my husband had an uncle who did that and that sort of stuff, but very common, but it is benign. Crigler-Najjar, these are rare genetic things, nothing you want to really see, and I don't think anything you need to know anything about it. Rye syndrome is something that most of you have probably not ever heard anything, but it's a very severe liver disease associated with ammonia levels that go up, and an encephalopathy that's associated. We used to see it with aspirin use with a viral infection. In particular, we saw it with chicken pox and with flu, and the use of aspirin. That's the reason that aspirin is basically not available for children unless they have to be on it for like a rheumatoid condition. So they start with vomiting, and then they get this encephalopathy, and their liver functions go out the wazoo. Alpha-1 antitrypsin deficiency, it's supposed to be 1 out of 2,000 live births, but I will tell you that it is screened for on the genetic screen, and I've only had 1 while I've been here, and in 36 years, and most of them do extremely well. It can cause a progressive liver disease, and of course, it can cause some pulmonary issues too, but the one I've had has done well. Wilson disease, autosomal recessive, copper metabolism issues. If you'll see the Kaiser-Fletcher ring, that's something that'll sometimes show up on like boards and exam questions. Copper chelating agents will sometimes be treated with that. Hemochromatosis, excessive storage disease with iron. A couple of families in this area have had issues with that. If for some reason someone from one of those families has to be transfused, it can be a real problem. Cholelithiasis, once again, gallstones, right upper quadrant pain, vomiting, and jaundice. Certain children are predisposed. Sicklers, patients who have to be on TPN for a long period of time, or INF, or hyperalimentation, whatever term you all use. Kids who have had short bowel syndrome, who of course are going to be on TPN and stuff. Adolescents, and particularly adolescent pregnant females. Pancreatitis can occur with it. If you happen to just pick it up, like sometimes we'll do a KUB and we'll see gallstones on there. If it's, if they're not bothering them, we don't do anything about it. There's usually nothing you can do therapy-wise except get it out there if they are symptomatic. They don't necessarily have to have stones, and so sometimes they will just have the inflammation and stuff. And so sometimes we have to do a scan for that. Ultrasound is the best way to do it, and IV fluids and bowel rest, and sometimes antibiotics before you think about even getting it out of there. Hydrops of the gallbladder, very unusual, is associated with Kawasaki's and or strep sometimes. Prolonged fasting, once again, usually not something we see around here, and diagnosed by ultrasound. And hepatoblastoma. One of my best friends in medical school, his brother died of hepatoblastoma while we were in medical school. His younger brother was 15 at the time. Associated with the elevated alpha-fetoprotein, and it still, to this day, has not changed in its survival rate, which is 50% for 5 years, and it's the most common malignant liver tumor in children. And that's in. I thought my cartoon was cute. It says, "It's okay, I've got diarrhea of the mouth." All right. All right. Thank you, guys.
Very good, Dr. Sowell.
All right. Any questions? Can I ask, anybody have any questions? I know I flew through that. I'm sorry.